Liver cell failure, etiology, infections, viral hepatitis B, C, and D, chemicals, alcohol, DDT, hallucin, paracetamol, iron H, physical, severe burns, hyperthermia, terminal stage of liver cirrhosis, chronic hepatitis, obstructive jaundice, and malignancy, clinical picture of liver cell failure, fatigue, anorexia, loss of weight, fever, fetal hepaticus, jaundice, ascites, encephalopathy, skin manifestations, endocrine, cardiovascular, hematological manifestations, and finally hepatorenal syndrome. Fatigue is the most common manifestation, with anorexia and loss of weight, fever, low grade and prolonged, due to necrosis of liver cells leading to release of pyrogens, stimulating the heat regulatory system, bacteremia due to failure of liver to clear bacteria from the circulation, and also bacteria bypass the liver through the portosystemic shunts, reaching the systemic circulation. Fetal hepaticus, musty pungent breath odor, increased by constipation and decreased by defecation due to failure of hepatic detoxification of mercaptans, normally absorbed from intestine due to liver failure or shunts, excreted in mouth with breath. Jaundice, failure of liver to deal with bilirubin, ascites. It may develop gradually as a result of gradual deterioration of liver functions or acutely from GI hemorrhage, sepsis, hepatocellular carcinoma. Pathogenesis, we have 6 items: hypoalbuminemia, portal hypertension, increased aldosterone salt and water retention, peripheral arterial and splanchnic vasodilatation theory, lymphoria, and associated factors. Associated factors, we have spontaneous bacterial peritonitis, malignancy, TB, peritonitis, lymphoria, liver weeping, post-sinusoidal obstruction leads to increased lymph production into the peritoneum, peripheral arterial and splanchnic vasodilatation theory, mediated by accumulation of vasodilators, mainly nitric oxide, leads to pooling of blood into peripheral and splanchnic arteries. The vascular underfilling is sensed by the kidney, leading to activation of the RAS system, salt retention leading to ascites. Increased aldosterone, salt and water retention. In liver failures, there is decreased destruction of aldosterone. Hypoalbuminemia leads to hypovolemia, leads to decreased renal blood flow, activation of renin, angiotensin, and aldosterone. Portal hypertension. Alone, it doesn't produce ascites, but it acts as a localizing factor. It localizes the translate to the peritoneal cavity by increasing the hydrostatic pressure of the peritoneal vessels. Hypoalbuminemia, less than 3 gram percentage. This is the most important factor due to diminished synthesis of albumin by the liver. Patient with liver cirrhosis and ascites with normal albumin suspect other causes of ascites such as TB, peritonitis. Spontaneous bacterial peritonitis, infection of the peritoneal cavity in absence of known etiology, it may be spontaneous or follow previous paracentesis, occurs in 10% of cirrhotic patients with ascites due to loss of detoxification function of the liver. It's 90% monomicrobial. The infection is blood-borne. Infection with more than one organism is likely to be associated with abdominal paracentesis. The prognosis is very bad. Mortality rate 50%. Clinical picture, deterioration of liver functions, increased encephalopathy, ascites, or jaundice. Resistance to diuretics may be a sign of spontaneous bacterial peritonitis. And finally, rebound abdominal tenderness in a patient with ascites is the most clinical sign. High fever, severe abdominal pain. Cirrhotic patients with ascites and evidence of any clinical deterioration should undergo diagnostic paracentesis to exclude spontaneous bacterial peritonitis. Diagnosis. The key of diagnosis is the examination of the ascitic fluid. Neutrophils count exceeds 250 cells per mm power 3, Culture, monomicrobial, E. coli, pneumococci, and Klebsiella. Treatment, cefotaxime or cefotaxime, ciprofloxacin, amoxicillin, clavulanic acid. Cefotaxime 2 grams 3 times per day IV, or ciprofloxacin 400 milligram per 12 hours for 5 to 10 days. Notice that minimum duration is 5 days of treatment is recommended. Prophylaxis, we give oral norfloxacin 400 milligram per 12 hours for minimum of 7 days is currently recommended in those with history of spontaneous bacterial peritonitis or those presenting with upper GI hemorrhage. Clinical picture and investigations of ascites. Ultrasound, it can detect as little as 30 milliliters of ascitic fluid with the patient in the right lateral decubitus position. CT of the abdomen may detect small amounts of ascites and at the same time evaluate the intra-abdominal anatomy. Diagnostic paracentesis and fluid may be sent for lab tests such as gram stain, cell count, bacterial culture, amylase level, albumin level, and serum acetic albumin gradient, SAG, SAAG. It's serum albumin minus acidic fluid albumin concentration. The clinical value, if it exceeds 1.1 or equals to 1.1, it indicates that the ascites is due to portal hypertension regardless the cause. While if it's less than 1.1, then this means it's exudative ascites, non-portal hypertension etiology, such as vasculitis, pancreatitis, nephrotic syndrome, cancer, primary or metastasis, infection, TB, or spontaneous bacterial peritonitis. Treatment, salt restriction, less than 2 grams per day, cornerstone of therapy, diuretics, spironolactone from 100 to 400 milligram per day, drug of choice in full dose, Lasix from 40 to 160 milligram per day. Excessive diuresis may result in azotemia, hyponatremia, hepatorenal syndrome, and finally encephalopathy. Taping or paracentesis indicated in the following conditions: sampling to relieve respiratory distress and to relieve compression on the kidney, albumin infusion to correct the osmotic pressure of the plasma, peritoneovenous shunt or a Levine shunt to drain the acidic fluid into the circulation, complications, septicemia, DIC, hypervolemia, and heart failure. Treatment of the cause, antibiotics for spontaneous bacterial peritonitis and liver transplantation. Ascites mustn't be treated if there are marked manifestations of liver cell failure, such as hepatic encephalopathy, wet and wise, better than dry and drowsy. Refractory ascites, ascites with lack of response to 400 mg spironolactone plus 160 mg Lasix daily with salt-restricted diet for at least 1 week. Skin manifestations due to accumulation of vasodilator materials, especially estrogen and nitric oxide. We have palmar erythema, spider nevi, paper money skin, white nails or riconychia. Clubbing. Clubbing complicates cirrhosis in hepatopulmonary syndrome. White nails, white fingernails may be related to hypoalbuminemia and may be seen in severe liver diseases and or malnutrition. Paper money skin, numerous small vessels scattered in skin over bony areas, dorsum of the foot and hand, forehead and chest. Spider nevi, more common than palmar erythema, vascular lesions usually found in the distribution of superior vena cava on the face, trunk, upper part of the arms. This distribution is not understood. It consists of a central dilated arteriole with radiating capillaries. Compression of the central arteriole causes blanching of the radiating capillaries. They are found in pregnancy. Multiple spiders and finger clubbing suggest hepatopulmonary syndrome. Few spiders are not sufficient to diagnose liver disease, but many new ones with increasing size of the old ones should elevate suspicion. Palmar erythema, erythema in head of metacarpal bones, thenar and hypothenar with central pallor. The sole of the feet may be affected, also seen in pregnancy, rheumatoid arthritis, and thyrotoxicosis. Endocrinal manifestations due to disturbance of sex hormones in males, gynecomastia, female distribution of suprapubic hair, impotence, decreased libido, and testicular atrophy. For females, amenorrhea, sterility, atrophy of breast with decreased libido, increased aldosterone and ADH in males and females. Cardiovascular manifestations, accumulation of the vasodilator materials formed by the sick hepatocyte or failure to be inactivated by it or bypass it through the portosystemic shunts. Vasodilator materials, for example, are adenosine, estrogen, prostaglandins E1, 2, and 12, nitric oxide, potent endothelium-derived vasodilator, hyperdynamic circulation due to anemia and the vasodilator materials. Then we have cyanosis and clubbing due to hepatopulmonary syndrome, due to opening of the intrapulmonary AV shunts, normal ventilation with reduced perfusion because blood will be shunted across the collaterals from pulmonary arterioles to the venous side directly without passing to the alveoli, or from portopulmonary shunts, or from basal lung collapse due to ascites. Those three causes lead to cyanosis and clubbing. And finally, we have cardiac dysfunction due to inhibitory effect of circulating cytokines such as nitric oxide on the ventricular function, or neurohormonal hyperactivity. The RAS system leads to myocardial growth and fibrosis with disturbed relaxation. This cardiac dysfunction remains clinically silent, masked by the afterload reduction, which is observed in cirrhosis, so cardiac reserve may be diminished and acute heart failure may be manifested after TIPS or liver transplantation. Hematological manifestations, anemia and bleeding tendency. Bleeding tendency due to hypofibrinogenemia, hypoprothrombemia, hypersplenism leading to thrombocytopenia, reduced vitamin K levels and reduced factors F972, 2, 7, 9 and 10, Anemia, normocytic, normochromic, due to bone marrow depression by toxins or hypersplenism. Macrocytic, vitamin B12 and folic acid deficiency. Microcytic, hypochromic, from iron deficiency anemia due to chronic blood loss. Hepatorenal syndrome, functional renal failure with normal renal histology in patients with advanced liver cirrhosis or fulminant hepatic failure. Pathophysiology. The hallmark of hepatorenal syndrome is renal vasoconstriction. The exact mechanism is unknown, but it may be due to hypovolemia, due to hypoalbuminemia, ascites, and diuretics. Cardiac dysfunction associated with hepatic disease is a recent theory. And finally, we have the peripheral splanchnic arterial vasodilatation theory, which will lead to renal vasoconstriction. Criteria of diagnosis, we have 5 criteria: absence of shock or current treatment with nephrotoxic drugs, no sustained improvement after withdrawal of diuretics and expansion of plasma volume, no ultrasound evidence of obstructive uropathy or parenchymal renal disease, chronic or acute liver disease with advanced hepatic failure and portal hypertension, and finally we have low glomerular filtration rate, serum creatinine more than 1.5 mg percentage, or 24-hour creatinine clearance is less than 40 milliliters per minute. Types, we have type 1 and type 2. Type 1, rapidly progressive type with high mortality rate. There is doubling of the serum creatinine to level greater than 2.5 mg per deciliters in less than 2 weeks. Type 2 hepatorenal syndrome, slower progressive course with serum creatinine of more than 1.5 mg per deciliter with better prognosis. Precipitating factors, systemic infections such as spontaneous bacterial peritonitis, excessive diuretic therapy, diminished intravascular volume from diarrhea, and large volume paracentesis of ascites without volume expansion. Prognosis, very bad. Treatment, IV albumin, plasma expansion, systemic vasoconstrictors such as somatostatin analogs, octreotide, and finally liver transplantation is the best choice. Hepatic encephalopathy, definition, neuropsychiatric syndrome seen in patients with acute or chronic liver cell failure or portosystemic shunts. Types, we have 3 types, A, B, C. A, for acute liver failure. B, associated with portosystemic shunt, and C, associated with cirrhosis. Precipitating factors, in majority of cases, type C occurs in response to well-recognized precipitating factors such as GIT bleeding, increased protein intake, old blood transfusion, increases ammonia, aspiration of ascites, diuretics, furosemide, leads to decreased level of potassium ions and alkalosis. Others, we have spontaneous bacterial peritonitis, surgery, portosystemic shunts, drugs such as morphine and benzodiazepines. Pathogenesis, 3, alkalosis, hypokalemia, disturbance of amino acids, and finally production of toxic substance. Production of toxic substance by the action of bacteria on intestinal proteins leads to production of ammonia. It interferes with Krebs cycle, leads to production of inhibitory neurotransmitters such as GABA and glutamine, mercaptan, benzodiazepine-like compounds. Disturbance of amino acids, decreased branched chain and increased aromatic chain amino acids, leading to formation of false neurotransmitters such as octopamine and decreased production of normal neurotransmitters such as noradrenaline. Alkalosis and hypokalemia, decreased glucose entry to cerebral cells leading to coma, increased renal production of ammonia, increased permeability of the blood-brain barrier to some of toxic substances. Ammonia theory, ammonia is detoxified by the liver by conversion of it to urea, 2 factors contributing to the hyperammonemia seen in cirrhosis. Shunting may divert ammonia-containing blood away from the liver to the systemic circulation, and decreased mass of functioning hepatocytes leads to fewer opportunities for ammonia to be detoxified by the above processes. Ammonia crosses the blood-brain barrier, metabolized by astrocytes. Cells in the brain constitute 30% of the cerebral cortex, and they use ammonia to synthesize glutamine from glutamate, which is an inhibitory neurotransmitter. Increased levels of glutamine increases osmotic pressure in astrocytes, leading to their swelling. And it's important to notice that patients with hepatic encephalopathy have Alzheimer type 2 astrocytes. And finally, we have the clinical picture: pre-coma and coma. Pre-coma, sleep, inverted sleep rhythm, day-night reversal. Any metabolic error can do that. Speech, slow and slurred or monotonous. Apathy, slow response to questions. Astraxis, flapping tremors. disorientation to time, place, and persons, defecation and micturating in appropriate places, disturbed behavior, childish attitude, phasic excitation, and depression. Causes of bilateral astraxis: we have any organ failure, hepatic, renal, cardiac, or respiratory. Metabolic abnormalities: hypokalemia, hypoglycemia, hypomagnesemia. Drugs: alcoholism, phenytoin, barbiturates. Wilson's disease. Unilateral astraxis: focal brain lesion, midbrain or internal capsule. Flapping tremors or astraxis: non-rhythmic, asymmetric, involuntary, sustained posture of extremities, head and trunk. It can be bilateral but not bilaterally synchronous. One side may be affected more than the other. It disappears in coma, absent at rest, less marked on movement and maximum on sustained posture. It can be seen when the patient's arms are outstretched and fingers separated, or by hyperextending the wrist with the forearm fixed. So we have coma, irritable coma, differential diagnosis of irritable coma, hypoglycemic coma, and hepatic coma. Clinical stages of hepatic encephalopathy: we have West Haven criteria, grade 0, 1, 2, 3, 4. 0, we have no abnormality detected, just minimal changes in memory, concentration, and intellectual function with coordination, no astraxis, and there is no abnormality in the EEG. Grade 1, triphasic waves, 5 cycles per second, plus or minus astraxis, and we have inverted sleep rhythm, euphoria or depression, impaired performance of addition or subtraction, trivial or insignificant lack of awareness. Grade 2, we have lethargy, apathy, disorientation to time, slurred speech, obvious astraxis, and personality changes with positive triphasic waves. Grade 3, sleepy, but he responds to verbal stimuli, gross disorientation to time and place, marked confusion and amnesia, incomprehensible speech with triphasic waves and astraxis. Grade 4, coma, unresponsive to voice pain, decerebration, so we don't have astraxis. And for EEG, we have delta activity. Diagnosis can usually be made clinically, but when doubt exists, we perform EEG. It shows diffuse, slow triphasic waves. Ammonia level, it's elevated, but it's not a sensitive or specific test for hepatic encephalopathy. Treatment: 6 items. Hospitalization to the ICU. Endoscopy should be done to localize the site of bleeding. Diet: protein restricted. Carbohydrates are increased to decrease protein breakdown as source of energy. Fats in small amount to produce mild diarrhea, which is useful to wash intestine. Potassium excess in fruit juices. Enema each 4 hours to wash the colon. Antibiotics to prevent the action of intestinal bacteria on proteins. Neomycin 1 gram per 6 hours orally. Its side effect is nephrotoxicity. Metronidazole 500 mg each 6 hours. Rifaximin 400 mg 3 times per day. Lactulose 30 to 120 milliliters 3 times per day, oral or rectal, to produce osmotic diarrhea, to wash the colon, and to produce acids, which promotes conversion of luminal ammonia into ammonium, which is non-absorbable. And finally, we have liver transplantation. Sedatives should be avoided, but if necessary, we give small doses of diazepam. Morphine is absolutely contraindicated. We have drugs of doubtful value, such as branched amino acids, bromocriptine and L-DOPA to improve neurotransmission, benzodiazepine antagonists, flumazenil, and finally we have ornithine L-aspartate. It reduces the level of ammonia. Then we have portal hypertension. Its elevation of portal venous pressure above 12 mm mercury. The normal is from 7 to 10. Etiology: the most common cause of all is liver cirrhosis. It's divided into suprahepatic, hepatic, and infrahepatic. Suprahepatic: cardiac cirrhosis, right-sided heart failure, tricuspid regurg, pericarditis, IVC obstruction, and Budd-Chiari syndrome. Hepatic, the most common, we have sinusoidal and post-sinusoidal with pre-sinusoidal. Sinusoidal and post-sinusoidal liver cirrhosis is the most common cause, veno-occlusive disease. Pre-sinusoidal, we have Hodgkin lymphoma, leukemia, congenital fibrosis of the portal tract, and schistosomiasis or bilharziasis, periportal fibrosis. Infrahepatic, rare, portal vein thrombosis from hepatoma, congenital stenosis of portal vein, and extrinsic compression from tumors. Cirrhosis is the main cause of portal hypertension by trauma caused by cirrhosis, creating AV shunts or fistula between hepatic arterioles and portal vein. Liver cirrhosis and regenerative nodules increase the portal pressure by compression. Pathophysiology. Portal vein formed by union of superior mesenteric and splenic veins. Portal hypertension leads to spleen congestion, intestinal congestion, and portosystemic shunt to decompress the portal hypertension, leading to development of collateral channels, esophageal varices, caput medusa, hemorrhoids, shunting of toxins from the intestine to the general circulation, leading to hepatic encephalopathy. Clinical picture, 6 items: splenomegaly, intestinal congestion, liver, ascites, encephalopathy, and portosystemic shunt. Splenomegaly, dragging pain in the left hypochondrium. It may be the only clinical evidence for portal hypertension. It may be associated with hypersplenism, leading to pancytopenia and bleeding tendency, and there is no relation between the size of spleen with the severity of portal hypertension. Intestinal congestion, dyspepsia, distension. Liver, firm, sharp border, cirrhotic liver. Ascites, sag, equal to or more than 1.1. It's a localizing factor rather than a cause. Encephalopathy, pre-coma and irritable coma, as previously mentioned. Portosystemic shunt to decompress the portal hypertension. Main sites for collaterals, lower end of esophagus, around the umbilicus and anal canal. Portal circulation and systemic circulation in the lower end of esophagus. Portal, coronary veins of stomach, systemic azygous vein. Portal for around umbilicus, umbilical vein in the falciform ligament, and systemic veins of anterior abdominal wall. For the anal canal, portal, superior and middle rectal veins, and systemic inferior rectal vein. Clinical presentation for lower end of esophagus, esophageal varices with or without bleeding, around the umbilicus, caput medusa flowing away from umbilicus. Anal canal may be mistaken for hemorrhoids. Actually, piles never occurs because of being far from the portal vein to transmit the pressure, and the perianal sphincter is always in tonic contraction, which compresses the veins. Complications of portal hypertension, we have 6 items: esophageal varices, ascites, portosystemic encephalopathy, hypersplenism, congestive gastropathy, bleeding, and finally renal failure. Esophageal varices, dilated elongated tortuous veins located at the lower end of the esophagus. Etiology: portal hypertension is the only cause of esophageal varices. Clinical picture: approximately 90% of cirrhotic patients develop esophageal varices over 10 years, but only a third of them will bleed. Bleeding is likely to occur with large varices and in severe liver diseases, and we can expect the bleeding by red signs in endoscopy. Before rupture, asymptomatic, dysphagia, rare. At rupture, painless, massive hematemesis with melena. Because other etiologies of upper GI bleeding are also common in cirrhotics, such as gastritis and peptic ulcer, variceal bleeding should be confirmed with endoscopy, even in patients with known varices. Investigations of portal hypertension or esophageal varices: endoscopy to detect early varices, detect signs of impending rupture, red signs, detect active bleeding and its site, and can be used for sclerotherapy of varices. Imaging of portal circulation, CT, MRI, Doppler or duplex ultrasound to detect pressure, velocity, and patency. Measurement of hepatic venous pressure gradient, the gradient between the free hepatic venous pressure and wedged hepatic venous pressure. The gradient shouldn't exceed 5 mm mercury or equals to 5 mm mercury. This is the normal. But if it exceeds 5 mm mercury, this is diagnostic for portal hypertension. Splenoportography. A needle is introduced into the spleen. Inject dye for patency of portal vein. Evaluation of the liver by the lefts, liver function test and liver biopsy. Investigations of bilharziosis, barium enema. Non-invasive techniques to look for significant portal hypertension or varices are of limited value. Thrombocytopenia, splenomegaly, and liver function tests can be all abnormal in absence of esophageal varices. Treatment of portal hypertension. Treatment of esophageal varices, of ascites, and of portosystemic encephalopathy. For esophageal varices, during the attack, control of acute bleeding by initial resuscitation with replacement of blood volume, endoscopy to detect the site of bleeding, pharmacological therapy by vasopressins, somatostatins, octreotide, and terlipressin, long-acting analog of vasopressin. Vasopressin leads to vasoconstriction of mesenteric and hepatic arterioles, decreasing portal inflow, decreasing portal vein pressure, and decreasing hemorrhage. The dosage: 20 units in 200 milliliters, glucose 5% over 20 minutes. Side effects: generalized vasoconstriction leading to peripheral vascular ischemia, ischemic heart diseases, and hypertension. We may use nitrates with vasopressin. Somatostatin and octreotides are safer. Whatever drug is used, we shouldn't use it for more than 1 to 2 days. Pharmacological therapy can be initiated as soon as variceal hemorrhage is suspected, even before diagnostic endoscopy. Number 4, injection sclerotherapy and or band ligation. The efficacy of rubber band ligation is similar to sclerotherapy with fewer complications. The complications are esophageal ulceration, stricture, chest pain, and aspiration. Band ligation is considered the treatment of choice. Then we have Singstaken Blakemore tube, mechanical compression of esophageal varices. Diagnostic value used in the case of hematemesis if the bleeding doesn't stop and the source is not esophagus. Therapeutic value, bridge to endoscopic therapy if bleeding doesn't stop by conservative treatment and if endoscopy is not immediately available. Side effects, esophageal perforation and ischemia if it's done by inexperienced people. When all the above measures fail, we use TIPS or portosystemic shunt operations. TIPS is transjugular intrahepatic portosystemic shunt. Prevention, primary prevention for silent varices and secondary prevention. Primary prevention for prevention of the first variceal bleeding, small varices, less than 5 mm, no signs of impending rupture, no treatment is required. Large varices, more than 5 ml, we use nitrates, venodilators, beta blockers, propranolol or carvedilol. Although beta blockers therapy will not prevent varices from forming, but it can reduce the incidence of GI hemorrhage by 40% by decreasing the cardiac output and splanchnic vasoconstriction. Impending rupture, band ligation, endoscopic variceal ligation, prophylactic injections, sclerotherapy has no role in primary prophylaxis. Secondary prevention, prevention of recurrent variceal bleeding, beta blockers decreases the risk of rebleeding up to 40%. Injection sclerotherapy or band ligation till varices disappear. TIPS portosystemic shunt and liver transplantation considered in patients who rebleed during the above measures. TIPS transjugular intrahepatic portosystemic shunt, connecting portal vein with hepatic vein. It requires only light sedation and local anesthesia. Portosystemic shunt, portocaval, leading to encephalopathy side effect, mesentericocaval and lienorenal, minimal encephalopathy, 2 types, distal and proximal. And finally, Hassab operation, minor surgery, splenectomy and esophageal devascularization. GI bleeding divided into upper and lower. Upper, site of bleeding proximal to the ligament of threads, suspensory muscle of duodenum, distal duodenum. Presentation, hematemesis, melena, occult blood and stool. Lower GI bleeding, site of bleeding distal to the ligament of threads. Presentation, melena, occult blood and stool with hematochezia, bleeding per rectum. Hematemesis, vomiting of blood coming from esophagus, stomach, and duodenum. Blood may be red in color if immediately after bleeding. Coffee ground or melanemesis when blood is in contact with gastric acid for at least 1 hour. Etiology, esophageal, gastroduodenal, and systemic. Systemic, hemorrhagic fever, hemorrhagic blood diseases, heparin therapy, and severe hypertension. Gastroduodenal, gastric ulcer, duodenal ulcer, gastritis, and cancer. Esophageal varices, cancer, esophagitis due to infections and GERD. Mallory-Weiss syndrome, mucosal tear of the esophagus, mostly at the gastro-esophageal junction due to repeated violent coughing or vomiting. Treatment self-limited and vasopressin may be used. Diagnosis of hematemesis. History, it depends on the cause. For esophageal varices, history of cirrhosis, confusion, peptic ulcer, epigastric pain, dyspepsia, heart pain, gastritis, history of drug intake, aspirin, alcohol, NSAIDs, epigastric pain. Cancer stomach, weight loss, meat dyspepsia, Mallory-Weiss preceded by severe vomiting, coagulation defect, oral anticoagulants, and history of cutaneous or orifice bleeding. Examination, manifestations of the cause, chronic liver disease. Assessment, loss of less than 500 milliliters, no detectable physiological changes. Exceptions include elderly and anemic. Loss of 1000 milliliters produces orthostatic changes of 10 to 20 millimeter mercury drop in systolic blood pressure and pulse rise of 20 beats per minute. Loss of 2000 milliliters produces hypovolemic shock, pallor, cold sweating, thirst, oliguria, low systolic blood pressure less than 100, tachycardia more than 100, tachypnea. Manifestations of iron deficiency anemia in a case of recurrent bleeding. Investigations, nasogastric tube, positive for blood, endoscopy to localize the site of bleeding, angiography if endoscopy fails to show the site of bleeding, lab, CBC, and liver function tests. Treatment of hematemesis, resuscitation, IV fluid and fresh blood transfusion if necessary, endoscopy, treatment of the cause, esophageal varices and peptic ulcer, IV PPIs, omeprazole or H2 blockers, iron therapy given in chronic cases presenting with iron deficiency anemia, differential diagnosis of hematemesis, differential diagnosis of the causes, and hemoptysis, false hematemesis from ingestion of blood after bleeding from mouth, nose, or pharynx, then vomiting of the blood. Melena, passage of black tarry stool due to presence of digested blood, indicates that hemorrhage remained for 8 hours or more in the GIT. At least 60 milliliters of blood is required. Site of bleeding, not merely above the ligament of Treitz, because hematemesis may extend up to the right colon above the ileocecal valve. Etiology of the upper GI bleeding as previously mentioned, jejunum and ileum, typhoid ulcer, TB, enteritis, cancer head of pancreas, Crohn's disease, colon, ulcerative colitis, and right-sided tumor. Differential diagnosis for dark stool, hemolytic jaundice, iron ingestion, and melena. Diagnosis and treatment of melena, same as hematemesis. Risk assessment of upper GI bleeding, AIM S65. Simple, accurate, non-endoscopic risk score can be applied early within 12 hours of hospital admission in patients with acute upper GI bleeding. It's based only on clinical and lab features. If it's more than or equal to, it predicts high in hospital mortality. AIM S65. Albumin less than 3 mg per deciliter, 1 point. INR exceeding 1.5 equals 1 point. Mentality altered, Glasgow scale less than 14, 1 point. Systolic blood pressure less than 90, 1 point. Age more than 65 years, 1 point. So the total score is 5. Hematochezia, passage of bright red blood per rectum, usually indicates lesion distal to the right colon. Etiology, anal lesions, hemorrhoids and fissures. Diverticulosis, most commonly seen in sigmoid. Polyps, ulcerative colitis, infectious colitis. Colonic cancer, usually present with chronic occult bleeding. Diverticulosis, the most common cause of acute lower GI bleeding in patients more than 40 years. Diagnosis of hematochezia, barium enema, lab anemia, nasogastric tube negative, clinical history, PR examination and colonoscopy. Avoid flexible sigmoidoscopy and barium enema in the initial stages of diverticulitis because it leads to perforation. And finally, occult GIT blood loss, normal appearing stool with positive blood presence. And this concludes our part for today.